Okay, you're live on YouTube. I'm going to start the webinar now.
Welcome all to this session on macroscopic examination of gynecological specimens. This webinar is sponsored by the British Association of Urological Pathologists, the British Association of Gynaecological Pathologists, and the Journal of Clinical Pathology. It's a part of a series of webinars. So there are 6 webinars in total. So this is the 5th in this series. And the basis of these webinars are a series of papers published in the March 24 issue of the Journal of Clinical Pathology. This was a symposium on macroscopy under the microscope, focusing on macroscopy issues. I'm delighted to let you know that all these papers in the symposium have been now made open access, so you will be able to access these papers without requiring a subscription. So today's session is on the macroscopy of gynecological specimens, and this will be chaired by Professor Glenn McCluggage. Professor McCluggage is a consultant histopathologist at the Royal Victoria Hospital in Belfast, and he's an honorary professor at the Queen's University of Belfast. He is the past president of the International Society of Gynaecological Pathologists and the series champion for the ICCR Gynaecological Neoplasms. He's been involved with the WHO Blue Books and is the editor of the upcoming 6th edition of the tumors of the female genital tract. Glenn is the associate editor of histopathology, and as most of us know, he's a very prolific publisher. He publishes numerous articles, research articles, as well as review papers. and he's a much sought after lecturer and teacher. So I think, Glenn, it's over to you.
Thank you, Marley, for the introduction. I'm just going to share my screen. I'll just say at the outset we have three presentations on gynecological pathology, and we will take questions at the end of the session. If you're listening on Zoom, you could put your questions into the Q&A, and if you're listening and watching on YouTube, if you can put your questions into the chat, and we'll try to get to most of the questions if time permits. So I'm going to start off by talking about the macroscopy of ovarian fallopian tube and omentum. And this is what I'm going to try to discuss in the next 30 minutes. I'm going to start off with some general principles on macroscopic examination. Now, I know Murli Varma will have covered a lot of this yesterday, but I also know, these are standalone webinars. So some of you may not have heard his talk yesterday. And also repetition is good. It helps reinforce things. And then I'm going to talk about macroscopic examination and blocking of the omentum, the ovaries, and fallopian tubes. This is the first of the papers Murli referred to, the macroscopic examination of pathology specimens, some kind of interesting points in this. And just some tips about or important things about macroscopic examination, if you like. I think we all know that this is often underemphasized, but it really is the initial critical part of compiling a surgical pathology report, and it can be just as critical as microscopic examination and ancillary studies. And we also know this is sometimes left to relatively inexperienced persons, such as pathology trainees, and sometimes, there's limited guidance and supervision. I think there is some pressure to get it right the first time, since going back may be difficult. For example, it may be no longer possible to measure something. You may not know where the specific blocks have been taken from. And even if it's sometime later, the specimen may even have been discarded. Also, one thing to remember, it's important to record what organs are present or absent. And the examples I'm using, if you have an ovarian mass removed, it's important to document whether the fallopian tube is also there. And similarly, if you have a hysterectomy specimen, it's important to document that whether the cervix is present or absent, because obviously, if this is not mentioned, it's not mentioned in the pathology report, and the patient later develops something within the cervix, you look fairly stupid if it's not mentioned in the pathology report originally that the cervix was absent. There are various national and international protocols, which I'll refer to as I go through this talk. And I think something very important is that a common sense approach is needed with flexibility in the selection of blocks. And, it's true that in some pathology departments, which are under a lot of pressure, more blocks results in even more pressure. And so we really need to talk about judicious tissue sampling, because I think there is a risk of over or under blocking. At its most extreme, you could miss a lesion. If something's not sampled and it's missed in macroscopic examination, obviously the pathologist cannot report this. And at its most extreme, this could be an entire missed tumor. It could also be an area within a tumor with adverse prognostic features or management implications. For example, in a low-grade endometrioid carcinoma of the ovary, sometimes you get small foci of undifferentiated carcinoma, and if the tumor is not well sampled, that could potentially be missed. And another example would, if the deepest point of myometrial invasion is not sampled, this could affect staging and subsequent management. So just some other tips, I think we're all agreed that optimal fixation is very important. It's much easier to dissect and sample things if they're well fixed. And also, of course, the clinical context is extremely important. For example, if you're dealing with a hysterectomy specimen, you're going to have a totally different approach. If it's for something benign, such as uterine prolapse, the approach will be totally different if it's for an endometrial cancer. So obviously, the clinical context is very important. I also think the macroscopic description should be succinct and clinically relevant. So we don't need a lot of kind of things which are not clinically relevant in the macroscopic description. The point should be succinct and to the point. And of course, photography may be useful, and may be useful to include a scale on photographs. Murray may have talked about this yesterday, but what is a block? So protocols often state how many blocks should be examined from a tumor or a mass or a particular organ, but it's not clear, is a block a single cassette, or if there's more than one block or piece of tissue in a cassette, is this a single block or multiple blocks? And something which is very important to remember, even if we take sections from the entire tumor, you're only from a 3 to 4 millimeter tissue block taking a single 3 to 4 micron section. So even with complete examination of the tumor, you're really only seeing less than 1% of the specimen histologically. So therefore, really the focus should be on meticulous gross examination and sampling of macroscopically distinct areas. This is just an example. This is a single cassette, but you can see there's 3 separate tissue blocks here, and sometimes it's not clear, is this 3 blocks or is this 1 block? A few other kind of tips and general principles is that lesser blocking may be appropriate in macroscopically homogeneous tumors, whereas in tumors with macroscopically distinct and different areas, heterogeneous neoplasms, the different areas should always be described and the different areas should be sampled. And in some certain scenarios, you may need to go back. For example, in some scenarios in gynecological pathology, for example, with a radical hysterectomy specimens for cervical cancer, if LVSI is present, this may be one of the factors determining adjuvant treatment. So you may need to go back, the pathologist may need you to go back to take more sections in a case like this. So another thing which, I think is very important on a pathology report, and this comes from the specimen dissector, we do need a block key. We need a concise and accurate block key. And this is just from the ICCR data set. I'll talk about the ICCR in a minute. Really says the origins or designation of all tissue blocks should be recorded. And I feel ideally this should be documented on the pathology report. And this is particularly important if you're reviewing a case either within your own institution or from somewhere else. You need to be clear about the origin of each tissue block. And it also states, if it's not included in the final pathology report, it should be available on the laboratory computer system and relayed to the reviewing pathologist. And recording the designation of tissue blocks, this actually makes it easier if you ever have to go back to get a tumor block, for example, for research studies or for further immunohistochemistry or molecular analysis. Of course, the disadvantage of the block key in the pathology report is that to some extent it lengthens the report. Now, as I go through this talk, I'll talk about some of the international protocols, and I've just listed here the institutions, if you like, which produce cancer data sets. And depending on where we work, for example, in the UK, we follow the RC Path data sets. But I just want to mention the ICCR, or the International Collaboration on Cancer Reporting. And I want to mention this because, this is, I really think these are the best data sets, because these are put together by a panel of expert pathologists worldwide, and all the gynecological data sets have been developed by these expert panels. The gynecological data sets have been produced in association with the International Society of Gynecological Pathologists. And what really the aim of the ICCR is that once they put together their data sets, these will form the basis for local data sets such as the RC Path and the CAP data set in North America. And on the ICCR data sets, there are core or required elements, which, these are elements which are unanimously agreed by the panel to be essential for diagnosis, management, staging, or prognosis. And then you have other non-core or recommended elements, which we often include in pathology reports, but really don't meet the standard for core elements. And, you know, the ICCR data sets, they're useful to read if you're interested, because they do give a lot of data as to why the various elements are included as core or non-core elements. So moving on now then to talk about this is the paper was in the Journal of Clinical Pathology issue on gynecological specimens. So I'm going to start off by talking about omentectomy specimens. And I think one thing which is useful is for you to know, when is omentectomy likely to be undertaken? And one thing I would say is that different gynecological surgeons may have different thresholds for performing an omentectomy. For example, if it's a gynecological cancer surgeon, he may remove the omentum quite a lot, whereas if it's a gynecologist who mainly deals in benign diseases, they may not be they may not actually remove the omentum. And it also depends to some extent whether the procedure is a laparotomy or a laparoscopy. But, you know, omentectomy is often performed for a known or suspected or possible early stage tubo-ovarian carcinoma. Also, in advanced stage tubo-ovarian carcinomas and other gynecological neoplasms, when there's obvious omental involvement. And some endometrial cancers, especially aggressive types such as serous, or if there's a coexistent adnexal mass, the omentum will often be removed. One thing which is important to remember when we're talking about ovarian masses is that very often when an ovarian mass has been removed, it's really impossible to know definitively preoperatively whether this is going to be benign, borderline, or malignant. The radiology can give you some indication, but if the mass is confined to the ovary, it really may be very difficult to know if it's benign, borderline, or malignant. And this is unlike in other organs, such as the omentum, or such as the endometrium or the cervix, where these are usually biopsied, and you will know preoperatively that you're dealing with a malignancy. So, and even when you're dissecting an ovarian mass, you probably won't know if it's benign, borderline, or malignant unless a preoperative biopsy or frozen section has been performed. So the question, do we need to weigh or measure the omentum? Well, really the weight is of little value, but of course we tend to weigh these things. It's important to record the dimensions of an omental specimen, and this is because if a part of the omentum is being removed and the lesion within the ovary turns out to be malignant, the gynecological oncologist will want to know how much omentum has been removed. So this is really why we need to measure any omentum which has been removed. And another thing just to be aware is that specimens are sometimes described as omental biopsies when in fact they represent omental resections. So really the key to macroscopic examination and sampling of the omentum is thin slicing at 5 millimeter intervals. And if there's no obvious gross mass, you really need complete slicing with careful macroscopic examination and palpation. If there are obvious tumor nodules, I think it's useful to give an approximate number of the nodules. And important with ovarian tumors is substaging stage 3 ovarian cancers. You really need to know the size of the maximum tumor deposit within the omentum. So that should be recorded. Sometimes it's, the whole omentum is just indurated or grossly thickened without a well-defined tumor mass. And I would suggest you measure the whole of this area and use this as the size of the omental deposit. And sometimes you will find lymph nodes within the omentum when you're cutting these. So this is just really the substaging of stage 3 tubo-ovarian carcinoma, where the distinction between 3B and 3C is based on the maximum diameter of the tumor nodule within the omentum. Now, there are the international protocols for omental sampling. There are various recommendations, and most of them will actually suggest to submit 4 to 6 blocks from omental resections performed as part of staging for known or possible gynecological neoplasms. But, you know, I would say a lot of these recommendations are not evidence-based. A lot of the data sets recommend 4 to 6 blocks of a grossly normal omentum in patients with an ovarian carcinoma or a borderline tumor. But as I've already mentioned, you may not know the tumor within the ovary when you're cutting it as carcinoma or borderline tumor. So these are just some of the recommendations out there, but really I would say these are not really evidence-based. So these are just some suggestions personally for sampling the omentum, especially if resources are an issue. I think the degree of omental sampling can be dependent on the pathology of the primary neoplasm. So I think you need to use common sense and remember you can always go back and sample more. So I would say if the ovary is clearly benign on microscopy and on subsequent histology, for example, in macroscopy, if it's just a thin-walled cyst, you only really need 1 block of the omentum if it's macroscopically normal. If there's obvious gross tumor involvement, you really only need 1 to 2 blocks to confirm tumor. But if the ovary is borderline or malignant and the omentum is grossly normal, we need to take more, and it's usually recommended to take 4 to 6 blocks either up front or to go back. And then, you know, some of these tumors which I've listed here, like serous borderline, low-grade and high-grade serous carcinoma, etc., you may need more blocks because these are tumors which have a propensity for microscopic omental involvement. But if you're dealing with a mucinous tumor in the ovary, I'll come back to this, or a low-grade endometrioid carcinoma, you really only need limited sampling because if the omentum is grossly normal, because these tumors rarely involve the omentum. So another scenario which people sometimes get a bit confused about is that sometimes in a tubal ovarian high-grade serous carcinoma, the patient will be treated with a neoadjuvant chemotherapy to try to shrink down the tumor so the tumor can then be surgery debulked. So in this case, you should always know that you're dealing with a high-grade serous carcinoma because we really need to obtain a pre-chemotherapy biopsy for various reasons, you know, to order BRCA and HRD tumor testing, and the tumor may never be operated on, so you may not know the histological diagnosis. And post-chemotherapy, you often only get these small collections of tumor cells, sometimes with a lot of cholesterol clefts and a lot of inflammatory infiltrate. And we have a chemotherapy response score for tubal ovarian high-grade serous carcinoma, which should be included in all pathology reports of resections of these neoplasms following neoadjuvant chemotherapy. This is the chemotherapy response score. I'm not going to go over it in detail, but really what I want to mention is that some dissectors think post-chemotherapy, they need to take a lot of sections from the omentum to look for these microscopic foci of tumor. And I'll make the point that this chemotherapy response score was just designed to be for routine sampling of the omentum. So you don't need numerous blocks from the omentum post-chemotherapy if it's being removed. You just really need a routine sampling of the omentum. Now I'm going to move on now to talk about the tubal ovarian masses. Do we need to weigh and do we need to measure these? Again, the weight is of no clinical utility, but of course we generally do. The ovaries we really just need to mention and measure in 1 dimension. Now, a lot of the protocols and pro forma state 3 dimensions, but really only 1 dimension is really needed. And of course, you know, if it's all malignant tumor, it may be easy to measure, but, you know, just for the pathologist, you know, if you've just focal carcinoma in an endometriotic cyst or a focal carcinoma in association with a borderline tumor, you know, it may not be possible to measure these grossly. So really the dimensions of an ovarian tumor are not important for staging, prognostication or management. And So in the ICCR data set for tubo-ovarian carcinomas, this is actually the measurements for a non-core data element, but it really explains, there's little evidence that tumor size is of prognostic significance. And the principal reason for really recording the maximum tumor dimension is really to provide evidence that the tumor has been adequately sampled. And again, this is especially important in mucinous neoplasms. So probably the most important thing when you're dissecting ovarian mass is to look at the capsule very carefully, to look for defects, deficiencies, adhesions, or surface deposits. So whoever's dissecting the ovarian mass must mention the state of the capsule in gross inspection. And if the ovary has been previously opened and sliced into, whoever was doing that, must record the maximum dimension and the integrity of the capsule. And the reason for this is that whether it's a 1A, a 1C1, or a 1C2 really depends on the integrity of the capsule. And if this is not recorded, then it may be difficult to kind of substage stage 1 tumors. And this may, and the treatment may be different whether it's a 1A or 1C tumor. When dealing with a mucinous ovarian neoplasm, surface deposits may be a clue that you're dealing with a metastasis. I would say always take blocks from areas of capsular deficiency or tumor involvement. And I would also say the surface can sometimes be nodular or bossulated without capsular rupture. And another important thing which sometimes people forget to do, if you have nodules or papillary areas within a cystic lesion, you really need to document whether these are on the external or internal surface of the cyst. This is just showing, the difference between a 1A and a 1C tumor. It's the integrity of the capsule, and this is important for staging and for further management in some cases. So this is an ovarian mass. The capsule is nice and shiny and intact, so this must be recorded. And here's an obvious one where the tumor is actually rupturing out through the capsule. But if you're slicing into these tumors, before you do that, you must have a good look to see whether the capsule is intact or whether there are defects or tumor deposits. So what about sampling of ovarian masses? Again, most recommendations would state 1 block per centimeter of maximum diameter mass, but I would actually say the degree of sampling can be tailored depending on the gross appearance and also the tumor type. Now, of course, the tumor type, you may not know when you're dissecting this, but we can also go back and sample more. So I would say extensive sampling is not really needed for totally cystic thin-walled lesions with no solid papillary or nodular elements, even if very large, and you can put more than 1 block into a single cassette. But with a thin-walled cystic lesion, if there's solid papillary or nodular areas on the external or internal surface, you must sample these well. And again, with a uniform solid white-yellow ovarian mass, this is most likely to be benign, and more limited sampling initially may be appropriate. But in heterogeneous neoplasms, you should describe the different areas, solid and cystic, areas of hemorrhage, necrosis, etc., and always sample the macroscopically different areas. So here's a tumor which is relatively uniform throughout, and this is likely to be something benign, so you maybe don't need so many blocks. But this is one where there's solid and cystic areas, lots of different areas, so you need to describe these and sample all the different areas well. Similarly here, you have hemorrhagic areas, you have lots of different areas. You really need to sample this tumor very well. And just another example where you have tumor and then you have areas of necrosis and more hemorrhagic areas. So you need to sample these tumors very well. This is actually a serous borderline tumor with surface deposits. So when you get these papillary nodules in a cyst, you must really state whether these are in the internal or the external surface. And then the other thing of, the other scenario or the other factor which dictates how much of an ovarian mass you have to sample is the tumor type. And again, I've already mentioned, you may not, or you probably won't know this when you're dissecting the mass, but again, you know, the pathologist can always get you to go back and take more. And I would say some tumors like high-grade serous carcinomas and clear cell carcinomas are relatively homogeneous throughout, so you don't really need excessive sampling. But these other tumors, you may get admixtures of benign and borderlines. You really need to sample these well, especially mucinous tumors, and I'll talk about these just in a minute. A dermoid cyst, you know, I think if it's a thin-walled with hair and sebaceous material, you just need 1 or 2 blocks. But if there are any solid or different-looking areas, there is a risk of another malignant germ cell component or a malignancy arising in a teratoma, so you have to sample these well. So this is just a thin-walled dermoid cyst with hair. You don't really need to sample these very widely. But here's one with hair and sebaceous material, but there are lots of different areas, so you may need to sample this one a bit more widely. And sometimes we get torted ovarian masses. The question is, how much of these do we need to be sample? Now, in my experience, these torted masses are usually, but not always, benign. And really, what you need here is a really very thorough macroscopic examination to look for grossly viable areas, which are often actually seen around the periphery, and sample these. In my experience, of the whole thing is totally hemorrhagic and necrotic. Extensive sampling is really of limited value in picking up viable tissue. And these are just some blocks. You know, I see these being taken in patients with tubo-ovarian neoplasms. I don't really think we need parametrial blocks. We don't need excessive sampling of the endometrium in the absence of a gross abnormality, and we don't need lower uterine segment endometrial blocks. I just want to mention very briefly ovarian mucinous neoplasms, and just to make the point that within these ovarian mucinous neoplasms, you may get admixtures of benign and borderline and malignant areas, and the different areas may not look too different grossly. So really, for mucinous ovarian neoplasms, you need to sample well, since they may be very heterogeneous microscopically, and also there may be difficulties in distinguishing between a primary and secondary mucinous carcinoma within the ovary. You know, this is just an ovarian mucinous neoplasm with benign areas here and borderline areas over here, and this is one with a borderline area, and then this area of anaplastic carcinoma. So really, with a borderline or with mucinous neoplasms, you may need to sample these very extensively. This is just a study we published a few years ago on mucinous borderline tumors in Northern Ireland, and about 4% of these actually recurred or metastasized as mucinous carcinoma. And the most likely explanation for this is due to missing a small focus of carcinoma on the initial section. So the problem with ovarian mucinous neoplasms, they're often extremely large masses, and we really need careful gross examination with opening up of all the locules and preferential sampling of solid or necrotic areas. But there still is this potential to miss small focus of invasion or high-grade carcinoma, because you can never sample all. So the ICCR recommendations, and remember this is for mucinous borderline tumor, is 1 block per centimeter if it's less than 10 centimeters, and 2 blocks per centimeter if it's greater than or equal to 10 centimeters. But remember, you know, this is for mucinous borderline tumors. So, you know, if you think it's grossly obviously benign or malignant on initial assessment, you may need less, and you can always go back. This is just a mucinous neoplasm. We've all dealt with these, with this kind of very tenacious mucoid material. And here's one with lots of locules, and you really need to look up, to open up all the locules to look for more solid areas. And here's a mucinous carcinoma becoming more solid looking. These are just features in favor of a secondary mucinous carcinoma in the ovary, and you can see these ones I've highlighted at the top. These are ones which are going to be important. You're going to pick up in dissection of the specimen sometimes. This is a metastatic mucinous carcinoma in the ovary. So if you have a mucinous carcinoma in the ovary with surface deposits, you know, this is one clue you may be dealing with a metastatic mucinous carcinoma. So just the last few minutes, the last 4 or 5 minutes, I'm going to talk about sampling of the fallopian tubes. And, this is something which, I think there is some confusion out there. What is and when do we need to use the so-called CFIM protocol, and when is representative sampling of fallopian tubes appropriate, and what representative sampling should be undertaken. So this is really the CFIM protocol, where you're really sampling the whole of the tube, this longitudinal dissection of the fimbrial end, and then this transverse section of the rest of the tube. So when I started in pathology, we only got one section through the center of the tube, but now when you're using this CFIM protocol, you get lots of sections of fallopian tube to look at. And really why all this, all this emphasis has been on the fallopian tube is that we now know what we used to call ovarian high-grade serous carcinomas. Most of these actually arise from the fimbria of the fallopian tube. And and really this was just discovered relatively recently when we started looking at the whole of the fallopian tubes in these prophylactic risk-reducing salpingo oophorectomy specimens. And this is what we're looking for, this small microscopic lesion called STIC, or serous tubal intraepithelial carcinoma, at the fimbria of the tube, this high-grade nuclear atypia. And this is a small microscopic high-grade serous carcinoma, which you wouldn't see grossly. And this can be highlighted by this mutation type staining with P53 and this high MIB1 proliferation index. And, we have proposed these proposals for designating the site of origin of extrauterine high-grade serous carcinoma. And really, these are of tubal origin until proven otherwise. So really, what this means, if you can see in dealing with a high-grade serous carcinoma, again, you may not know you're dealing with a high-grade serous carcinoma, but you often have a clue, because these are often the tumors which are very widely disseminated. You really need to use this CFIM protocol when both fallopian tubes are grossly visible and grossly normal. And if there's any STIC or mucosal high-grade serous carcinoma in microscopy, then this is a tubal primary. And also, if the fallopian tube, the entire tuber fimbria, is not identified, it's obliterated by the mass, then this is also a tubal origin. So this is how we designate the site of origin of these extrauterine high-grade serous carcinomas now. This is just this entabulated form. And if you use this, about 83% of these extrauterine high-grade serous carcinomas turn out to have a tubal origin. So really, this is important for dissectors. When do we need to use this CFIM protocol? Because I say there is some confusion with this. In some institutions, they use the CFIM protocol for all cases when tubes are removed. But when you really need it is these prophylactic specimens in patients with this hereditary risk, BRCA1, BRCA2, and some of these other genes. Also, when there's a family history of breast or ovarian cancer, because some of these, they won't have had genetic testing or nothing will have come up. And also peritoneal washing should be performed in these cases. There are no real national recommendations, but we would recommend in prophylactic hysterectomies and BSOs for Lynch syndrome that you submit all the tubes and ovaries as well. And I've already mentioned, when you're dealing with an extrauterine high-grade serous carcinoma, you need to use the CFIM when there's two grossly normal ovaries and fallopian tubes. But I would say in these other scenarios, other tumors, benign indications, you don't really need to use the CFIM protocol. Though if you want to use it, that's fine. But when you're dealing with fallopian tubes, you should always document the presence or absence of the fimbrial end, and the fimbria should be entirely sampled with representative sampling of the non-fimbrial portion. The question is, how often do we see these incidental STICs? In risk-reducing specimens, the literature will say about 2 to 8%, but actually nowadays it's much less, because patients are undergoing their risk-reducing surgery at a younger age. With these extrauterine high-grade serous carcinomas, when the tubes are visible in their entirety and they're grossly normal, you actually see a stick or a small mucosal high-grade serous carcinoma in quite a high percentage of cases. But in the general population, actually, the pickup of stick is very rare. It's less than 0.01%. So, stick is very rare to be seen in the general population. This is just some of the recommendations we published for Lynch syndrome. And that's the end of my talk. We are going to take some questions later, but just at this stage, I'm going to introduce the next speaker, Dr. Karen Talia. Karen is online here, but her talk is being recorded. And Karen is going to talk about the gross examination of cervix, vulva, vagina, and placenta. So plenty to cover. Karen's an anatomical pathologist at the Royal Women's Hospital in Melbourne, Australia. She's a very well-known gynecological pathologist. She's associated editor of the journal Pathology. And really, I would describe her as an expert, especially in cervical pathology, but also all aspects of gynae pathology. So, Pretty, would you be able to share Karen's talk, please? Or to record?
Yes, I'll do that now.
Hi everyone, thank you for the introduction and for the invitation to participate in this important webinar. My name's Karen Talia. I'm joining from Melbourne, Australia, with my topics being macroscopic handling of cervix, vagina, vulva and placenta. Now, before I start, I thought I would summarise some general points relevant to each of the specimen types I'm going to discuss rather than repeating these throughout the talk. So the first thing is accurate documentation of the nature of the specimen that you've received. And this is particularly relevant to cervix, vulva and hysterectomy, where there are a number of different surgical excision types. And of course, this is determined by the surgeon. Clinical notes are vital. Often we receive specimens without a detailed clinical history, and I think we really should stop and look up the medical record prior to cutting up the specimen so that we have an understanding of why the surgery was performed and what the expected pathology is. The anatomical structures that have been removed should always be documented with a statement about whether or not the specimen is received intact or disrupted. And a disrupted specimen is particularly relevant to cervical excisions, which can come as multiple fragments. And in this setting, record the number of fragments and either measure these individually in 3 dimensions, or if there's multiple fragments, the overall aggregate dimensions will suffice with a size range from smallest to largest. In terms of measuring tumours, by convention, this is done in millimetres. Ideally, we measure all tumours in 3 dimensions, and if it's a mucosally or skin-based tumour, this is the 2 perpendicular horizontal or lateral dimensions, and then the estimated depth of invasion once the tissue has been sliced, which is measured from the mucosal surface to the deepest point of invasion. Strictly speaking, for staging purposes, 2 measurements will suffice, these being the maximum horizontal dimension and the depth of invasion. So if your preference is just to provide those 2 measures, that's sufficient. If the tumour is exophytic or ulcerated, tumour thickness can be measured in place of depth of invasion. Now, if possible, it's ideal to take all of these measurements in the fresh state prior to pinning out a specimen for fixation. And finally, a dedicated and detailed block key, supplemented if possible by a specimen photograph, which has been annotated, is essential. And each block that's submitted should be orientated to the specimen. So let's start with cervix. And much of what I'm going to be saying here is based on these recent consensus guidelines published by the International Society of Gynaecological in this open access issue of the International Journal of Gynaecology, which looked at problematic aspects of cervical adenocarcinoma. It included a dedicated paper on gross examination and intraoperative consultation, which is relevant to all tumour types in the cervix. The ICCR has also recently updated the dataset for cervical cancer, and this is another open access companion paper to that ICCR dataset. So these are both incredibly useful resources. And whenever I've taken images, as I have done from these papers, I've used the ISGYP logo to reflect that. And in preparing this talk across all of the topics, I've also referred to our local college, the Royal Australasian College of Pathologists Cut-Up Manual, which is a freely available online resource, which is pretty much our go-to when we're not sure about how to handle a specimen. And whenever I've taken images from that cut-up manual, I've used the RCPA logo. So there's a broad range of cervical specimens, and these range from tiny punch biopsies through to large radical excisions. And unfortunately, there's also a variety of methods for handling these macroscopically. I think loop excisions are the commonest, largest specimen that we see, and these come labelled either as a LEEP or a LETS, which are essentially synonymous terms that imply that the excision has been performed using a wire loop that simultaneously cuts and cauterizes the cervical tissue. Ideally, the loop is excised as a single circumferential pass surrounding the cervical os and incorporates the entire squamocolumnar junction, but this isn't always possible. So sometimes we get a specimen as several passes, and that's what I've depicted here in the images at the top. So you can see that the loop excision is incomplete from 3 to 6 o'clock and that a second pass has been taken. And in the image at the bottom left, only one half of the cervix has been taken in the first pass, with the other half received separately. And these sorts of specimens pose unique challenges for orientation and reporting, as not all margins in a multi-part specimen will represent true margins, and that needs to be taken into account. The larger surgical specimens include cold knife conizations, trachelectomies, and hysterectomies. The latter two can be simple or radical, through to pelvic exenteration, which is performed for more locally advanced tumours. And the images at the bottom right there depict a radical trachelectomy specimen. So the cervix is a conical structure, but the shape and size of the excisions do vary widely. Across the top, these 4 images are cold knife cone specimens, and this demonstrates some of the variety of appearances. So image A is tapered toward the deep aspect, whereas B is uniformly long and cylindrical. And C and D are somewhat rectangular and square-shaped by comparison. The LEEP specimens along the bottom, figure E is a lovely intact excision, which looks like it's been received unorientated. Image F has come as 2 passes, so we've got a first pass and then a second deeper pass, or a so-called top hat, which is done to gain a deeper excision of the endocervical canal. Image G, as is often the case, has become partially fragmented in handling and has opened out. And specimen H has been taken as 2 separate passes. Now, when it comes to measuring the cervix, we have a standard approach for all specimens, and that's to measure the ectocervix in 2 perpendicular planes, together with the specimen length, which equates with the length of the canal. So in an orientated specimen, these measurements are taken in the 3 to 9 o'clock and 12 to 6 o'clock planes, and the convention is the suture is placed at 12 o'clock. It's also useful to document the dimensions of the external os and its location. And as mentioned, in the setting of a disrupted specimen where you can't see the canal, each piece is measured in 3 dimensions. Now, if the specimen is received orientated, this should be documented, locate where the suture is situated, and use a clock face analogy, assigning the clock face as per the viewer's perspective. If the specimen is unorientated, you can then use the external os to provide some guidance in terms of orientation, as it's usually flat and linear in the coronal plane, as I've depicted with the arrows in the image at bottom left. And this provides partial orientating information. For a fragmented specimen, in order to try and orientate the tissue, you can generally be guided by the smooth and pale appearance of the mucosa relative to the roughened cauterized stroma. Now, inking practice varies widely. For a cauterized specimen, cautery artifact will tell you where the margins are. So strictly speaking, no ink needs to be applied. Whereas for a cold knife cone, ink will be required to reliably identify margins. Now, in an orientated specimen, we differentially ink the 12 and 6 o'clock halves different colors, even if there is cautery artifact. And you can also opt to do this in an unorientated specimen where you can use the os to designate the 2 halves of the cervix. And the rationale for doing this is that orientating the specimen in this way provides a more accurate assessment of the extent and location of the disease. And obviously, if a second pass of the deep endocervix is received, this should also be orientated with an attempt to mark the true endocervical margin with ink. Now, in terms of description and cutting of the specimen, any lesion that you see should be described along with its anatomic location and its distance to margins. And various methods, as I alluded to, for sectioning loop excisions exist. And the general principle is that we serially slice at 3 mm intervals and submit the entire specimen, trying to minimize the number of slices that we place in each block with accurate annotation of the origin of each slice in the block key. So one method for handling these specimens is depicted here, and this is relevant to those who receive their specimens in the fresh state, which we don't. We don't receive our loop excisions or cone excisions fresh, but if you do, you can ink it, open it in the midline anteriorly, and then pin it out overnight for formalin fixation, following which it would then be serially sliced parallel to the canal and entirely submitted. As is our practice, we receive all of our loop excisions and cone excisions in formalin, and there's two methods in this context for slicing, which is either parallel or radial. We use the parallel method, which means serially slicing the specimen in the sagittal plane. Now, if you've got no orientating information, you can put the end pieces together in one cassette and the central slices in remaining cassettes, which is the image in the center on the right. But if the specimen is orientated, then we should divide each individual slice and place it in its own separate cassette. And typically we do this from the 3 to the 9 o'clock end of the specimen. When you're placing the tissue in the blocks, it's important to put the cut surface nearest the endocervical canal face down. And when you're handling fragmented specimens, each individual fragment, if it's sizable, is transversely sectioned at right angles to the long axis and all submitted. And we tend to separate out these larger intact fragments and put them in their own individual block. Another variation on the parallel slicing method is to slice the end pieces longitudinally at right angles to the margins, as is illustrated here. We don't do this in our practice. If we've got, we put in whole single slices of the 3 and the 9 o'clock ends, and if we have lesion in those slices, we just cut deeper levels to assess their proximity to margins. The radial method entails slicing the specimen perpendicular to the canal in a clock face fashion, and this will result in wedge-shaped slices that are thicker at the stromal end, and this then necessitates trimming and submission of both the full slice and the trimmed portions of stroma. Okay, so moving on to trachelectomy. This is a fertility sparing procedure performed for small cervical cancers, usually larger than can be managed by a loop or a cone excision. A simple trachelectomy will include the entire cervix and attached 1 to 2 centimetre cuff of upper vagina, and a radical trachelectomy, which is what's pictured here, will include lower parametria. So these specimens, thankfully, are typically sent in the fresh state for frozen section to assess the proximal margin, and ideally we would ink, open, measure these specimens in the fresh state. So this is a recent specimen that we received for frozen section prior to inking, and you can see that there was an obvious tumour visible. Now, usually trachelectomies will come orientated by the surgeon, but if not, as was the case here, we orientated by looking for the presence of the downward extension of the peritoneum posteriorly. So we apply ink, we differentially ink the stromal surfaces of the anterior and posterior halves, and then ink the vaginal, endocervical and parametria margins as well. As is convention, measure the ectocervix in the 2 dimensions as I've described, along with the length of the canal, and also measure the wall thickness. Minimal and maximum length of attached vaginal mucosa should be recorded, and the parametrial dimensions in the mediolateral plane are also documented. Now, if there's an obvious tumour, this should be described. Is it exophytic? Is it plaque-like? Is it ulcerated? And also located relative to the ectocervix or the endocervix, and try and use some descriptors such as a clock face analogy to document where it's situated within the cervix. And tumour extent is also important in terms of how much of the cervix is involved and does it extend into the vaginal mucosa or the parametrial tissues. So measure the tumour using the method I've described with at least the largest tumour dimension and the depth of invasion and cervical wall thickness at this point once you've sliced the specimen. And again, as I mentioned, tumour thickness can be measured in place of depth of invasion if it's an exophytic or ulcerated lesion. The macroscopic distance to relevant margins should be measured. And here this is the epithelial and stromal margins. And ideally do all of this in the fresh state prior to pinning out to avoid any tissue distortion. Now, as with loop excisions, there's various methods for cutting these specimens. So we open a fresh specimen with a single cut parallel to the endocervical canal, ideally not through the tumour. And then have the option of pinning the specimen out, including the vaginal cuff for fixation. Typically, parametria are removed prior to pinning the specimen out for fixation, and they're fixed separately. So here's the pinned out specimen, and an advantage to pinning out is that it avoids the vaginal cuff retracting with fixation, which can impact measurements of the length of the cuff and the distance of the tumour to the vaginal margin. So once the specimen's been pinned out in this fashion, as per handling of the fresh cone specimen earlier, the specimen is serially sliced parallel to the endocervical canal. An alternative and perhaps a little unconventional approach that we used recently with this fresh specimen that we had a frozen on, and this is based on the fact that we like to cut our cervices using the parallel method, is we removed the parametria, measured everything, inked everything, and then reconstituted the specimen back into its original configuration. We placed a wick of paper soaked with formalin in the canal and loosely held it together with some string. So once it was fixed overnight, we were then able to serially slice in the sagittal plane and lay the slices out and photograph the slices for block annotation. The same parallel method can also be used, of course, if the tissue is received in formalin. Now, in terms of sectioning, if there's no visible tumour or the tumour is less than 2 centimetres in size, the entire specimen is submitted. And the rationale here is that final dimensions and stage can change after microscopic examination. Each slice ideally will incorporate the vaginal margin, the endocervical margin, the stromal margin, but if the tissue pieces are too large to fit into a single cassette, they should be judiciously divided. And that annotated in the block allocation. If the tumour is larger than 2 centimetres, representative sections are acceptable with a minimum of 1 block per centimetre of the maximum tumour dimension, demonstrating the deepest point of invasion, the maximum longitudinal extent, and the closest distance to margins. Now, in terms of handling the vaginal cuff, if it's short and left intact, it's sampled along with the cervix. If it's large, you may opt to remove it and handle it separately. At a minimum, sample the vaginal margin as a longitudinal section where the tumour lies nearest to that margin, and the remaining circumferential vaginal margin may be entirely blocked as strips en face or as representative perpendicular sections. And parametria are sliced and entirely submitted, noting the size and number of any tumour deposits or lymph nodes. Now, a hysterectomy in this context, obviously hysterectomy has been comprehensively discussed. I'll try and avoid any repetition and just concentrate on the setting of cervical pathology. So we see radical hysterectomies typically for cervical cancers, and this obviously includes the upper vagina and surgically dissected parametrial tissues, whereas a simple hysterectomy may also sometimes be performed for presumed small carcinomas. And in terms of the adnexal structures, these are variably removed, often guided by patient age and menopausal status. Now, we weigh our hysterectomies and we measure as per routine handling of hysterectomy for other indications. In terms of inking, ideally the anterior and posterior cervical non-peritonealized stroma is differentially inked, along with the vaginal margin and parametria, much the same as with the trachelectomy. So this specimen here at the right is a modified radical hysterectomy for cervical cancer in which the parametria have not been dissected and one ovary has been left behind. Now, there's two options for opening the specimen. You can amputate the cervix, and if it's fresh, handle as per an unfixed trachelectomy, and if it's fixed, cut sagittally or radially, and then handle the corpus in the usual way. And this means opening it either laterally in the midline, as is convention shown in the bottom image, or in the midline anteriorly, which we sometimes perform in the top image. An alternative method is to leave the cervix and the uterus entirely intact and bivalve the entire specimen. And this then means that you'll need to submit the cervix as radial slices. In terms of handling the parametria, if these are uninvolved, remove them first. As with a trachelectomy, serially slice and entirely submit, maintaining the laterality. If they're involved by tumour, you may leave them intact and slice them in continuity with the cervix as you're cutting it up. It's also worth saying that in simple hysterectomies, sometimes you may see small fragments of attached parametrial soft tissue, and these can be submitted as a shave. Now, in terms of describing and measuring the tumour, the same principles apply, and this is the same slide from the trachelectomy discussion, with the only additions being that you now need to factor in any extension of the tumour into the uterine corpus or involvement of the adnexa. Now, in terms of sampling, the approach to the cervix, the vaginal cuff, and the parametria is the same as for a trachelectomy. So if no tumour is seen, the entire specimen is submitted. For the uterine isthmus and corpus, sample any obvious tumour to document the extent of disease and submit representative full thickness sections of uninvolved isthmus and anterior and posterior corpus. Now, when you're sampling the isthmus, an alternative option that we use, which is relevant if the cervix has been amputated, is to take one transverse slice of the isthmus immediately above the amputation point and to submit that entirely. If a tumour is larger than 2 centimetres, representative sections of cervix will suffice, as previously described. And in terms of ovaries and fallopian tubes, basically sample any lesion, and then ISTIP recommends in the setting of cervical cancer that we should use the CFIM protocol for slicing, and at a minimum submit the entire fimbria, a representative section of the remaining tube and of the ovary. Now, pelvic exenteration, an uncommon specimen in my practice. It's an en-bloc resection of the uterus and vagina with or without vulvectomy, which is further classified as anterior, posterior, or total, depending on what additional structures are attached, be they the lower urinary tract, the rectosigmoid, or both. This is an uncommon procedure which is performed in the setting of locally advanced pelvic cancers in patients amenable to extensive surgical resection, and often where conventional radiation therapy has failed to control the disease. So before you start, you need to document all of the anatomical structures present and ideally measure these in the fresh state. Also look for any fistula formation and any effects of radiation therapy. Inking should concentrate on epithelial and stromal margins, with relevant epithelial margins including cutaneous, vaginal, urethral, etc. If the specimens receive fresh, you can inflate the bladder and the rectum with formalin and open the uterus and vagina and insert paper towel and then fix overnight. And once the specimen is fixed, it should then be hemisected through the tumour in the sagittal plane and take photographs of each of the cut surfaces to annotate when blocking. So measure the tumour in 3 dimensions, its proximity to all structures and to margins, and sectioning should be judicious and aim to demonstrate the maximum tumour extent and its relationship to other structures. So when the tumour is close to a mucosal surface, such as the bladder, vagina, or rectum, take sections perpendicular to the mucosa at the nearest point. Mucosal margins can be taken as en-face shaves, unless there's nearby tumour where a perpendicular or longitudinal section is preferable. And representative sections should be taken from any uninvolved organs. Okay, so let's move on to the vagina. I'm just going to be brief here. These are uncommon specimens, and to date there hasn't been a lot published on the handling of these, both at the cut-up and when reporting these specimens. And in response to this, the ICCR has recently developed a data set with recommendations for the reporting of primary vaginal carcinomas, and this is available on the ICCR website and is summarised in this open access paper in the International Journal of Gynaecology. So isolated vaginectomy is an uncommon procedure, and most complete vaginal excisions form part of a pelvic exenteration. And this reflects the fact that primary vaginal cancers are rare. So most vaginal cancers happen to be secondary, representing direct extension or metastasis, usually from an endometrial, cervical, or colorectal primary. So when we do get excisions, these are generally performed for small lesions confined to the vaginal mucosa, and they may represent either a wide local excision or a more extensive partial or total vaginectomy. Now, given the predominance of secondary tumours, it's critical in this setting that any relevant past history is obtained prior to reporting the case. And diagnosis of a primary vaginal carcinoma essentially requires exclusion of a cervical or other primary tumour. So this needs to be done at some point. Other relevant information is things like history of DES exposure, vaginal adenosis, or prior radiation therapy. So the approach to specimens follows all the usual principles with regard to orientating, measuring, inking of margins, description of tumour. It's important to document the location of a tumour in the vagina on the basis that the various primary tumour types show a predilection for different sites. Sectioning should aim to demonstrate the tumour at its deepest point of invasion, the interface with uninvolved epithelium, and its relationship to margins. Okay, vulval excision. So an important reference, again, when you're dealing with vulvar excisions is the ICCR dataset for vulval carcinoma. So this has been recently updated, and there's another open access companion paper that's very useful in the International Journal of Gynae Pathology. So before you start, it's important to obtain any relevant history, such as any known inflammatory dermatosis, prior diagnosis of a precursor lesion or malignancy, and any history of adjuvant therapy. Most of the disease we see is squamous cell carcinoma and its associated precursor lesions, be they HPV associated or independent. But excisions, of course, are also performed for other tumours such as melanoma and Paget disease. The specimen types range from wide local excisions to more radical partial or total vulvectomies. Wide local excision removes skin but spares the subcutis and deep soft tissues, and this is performed to excise pre-malignant lesions, often with a suspicion of malignancy, or for small vulval tumours. Partial or total radical vulvectomy removes tissue down to the level of the deep fascia and includes other local structures such as the clitoris and labia. And obviously the specimen type will be assigned by the surgeon. This should be clearly stated in the macroscopic description. So typically we receive these specimens orientated by a suture and, if we're lucky, even pinned out to a cork board, and they need to be well fixed prior to sectioning. So we start by measuring the specimen dimensions, describing which anatomical structures are present, such as urethral or vaginal orifices and the clitoris. Ink the cutaneous and deep strival margins, and if the specimen is small and whole slices will fit in a cassette, I think differential inking is useful to maintain orientation of the various slices. You may also want to ink relevant margins such as the vaginal or urethral margin in a different colour. If there's obvious tumour, describe it. State its anatomic location and what structures it involves. And this has prognostic importance as midline tumours are associated with the potential for bilateral lymph node involvement due to midline lymphatic anastomoses. It's also important to look at the adjacent skin and document any abnormal appearance. So in squamous cell carcinomas, typically there'll be adjacent VIN, which can form a plaque-like pale or red-coloured lesion. So measure the tumour as the usual 2 perpendicular horizontal dimensions and estimate the depth of invasion once the specimen is sliced. Also measure the distance to margins. Now there's various approaches to cutting the specimen. Most of our specimens are wide locals or partial vulvectomies. So typically we just simply serially slice at 3mm slices. And if there's no obvious tumour, the entire specimen should be submitted, as is the case in this example here. And you can see here that the location of the blocks has been really thoroughly documented with an annotated specimen photograph, which is very useful when you're reporting these cases. In terms of margins, it's really personal preference. Here we've captured obviously the 12 and 6 o'clock margins in our transverse slices, and we've opted to do 3 and 9 o'clock longitudinally. When there's a tumour present, again, we may opt to serially slice a specimen in smaller excisions and selectively submit slices that will demonstrate the deepest point of invasion, the interface with adjacent epithelium, and the relationship to epithelial and deep stromal margins. And in terms of margins in this example, we'll pick up the 3 and 9 o'clock margins in our transverse slices, and then we'll take longitudinal sections to represent 12 and 6 o'clock. So here's the annotated sliced specimen with the block selection. Now, if the specimen is a large total radical vulvectomy, which we seldom receive nowadays, you may choose not to serially slice the entire specimen in this fashion. And in this instance, just take representative sections of the tumour, the nearest margin, and other relevant margins, such as vaginal or urethral margins. And in that context, it's important to try and maintain specimen integrity so that you can easily return to it and submit more sections if needed. So in the last few minutes, I'm going to discuss handling of the placenta. Again, here are the references that I've used for this portion of the talk. I'm going to be focusing mostly on singleton placentas received in the setting of live births. And just so you're aware, there's some fantastic videos on the RCPA website demonstrating the macroscopic handling of the placenta, which is a really great resource if you're in need. So the reference we use most heavily when we're dealing with placentas, mainly for the reporting, is the 2016 paper from the Amsterdam group. So this is the Amsterdam consensus paper, which provides an approach to placental macroscopic examination, as well as definitions and diagnostic criteria for various lesions. And this is authored by a large international group of recognised experts in placental and perinatal pathology. So there's obviously a broad range of indications for a pathologic examination of the placenta. These are fetal, maternal, obstetric, and placental factors. And you'll need to devise a protocol within your own institution for referring placentas in consultation with obstetricians that you practice with. It's obviously critical to know why the placenta has been sent for examination, and we have provided our clinicians with this standard pro forma that ensures that all relevant clinical information is captured. So it includes relevant antenatal history, gestational age, birth weight, indication for the request. And then the next question is whether the placenta has been received fresh or in formalin. Ideally, these specimens are sent fresh so that tissue can be collected for relevant microbiological or cytogenetic studies. Now, placental weight is a surrogate for placental function, and it's important that this is measured consistently. Typically, this is the trimmed weight. So this is the disc trimmed of membranes, umbilical cord, noting the removal of any further tissue for ancillary investigations and the completeness of the maternal surface. Also noting if it's weighed fixed or fresh, as fixation does increase placental weight slightly. And when you're documenting placental weight, the contemporary weight standards relevant to your population should be cited. So each aspect of the placenta is systematically examined and described, and if there's any obvious macroscopic abnormality, photography of the intact specimen is encouraged. So we measure the disc in the usual 3 dimensions, noting the minimum and maximum thickness of the disc, and noting also the shape of the disc, any accessory lobe. In terms of the umbilical cord, measure its length, the range of cord diameters that are present, the insertion site, and the distance of this insertion site from the placental margin. Also noting whether there's velamentous, marginal, or furcate cord insertion. The number of cord vessels should be inspected and documented. Look at the coiling index of the umbilical cord and the colour of the cord, and also presence of any specific lesions such as cord knots. The membranes should be inspected. Important to document the colour, how clear or opaque they are, and whether they're complete. Note whether there's circumvallate or circummarginate insertion and the percentage involvement of the circumference of the placenta, and any lesions such as plaques or nodules or visible vessels in the membranes. Inspect the fetal and maternal surfaces, note the completeness of the maternal surface, any adherent or deforming blood clot or masses, and the percentage involvement of the disc. Likewise, the fetal surface, typically we're looking for visible thrombi and noting the percentage involvement of the disc. Now, when it comes to slicing and blocking, it's a standard approach. serially slice and systematically examine each slice. Any grossly visible lesion should be described and measured in 3 dimensions or its largest dimension. Estimate the percentage of placental parenchyma that's involved by the lesion, and also document the number of lesions and where they're situated within the placenta. Now, in terms of blocking, a minimum of 4 blocks is required. We start with a membrane roll, which is depicted here. It can be acquired in the fresh state, then fixed in order to improve the ease of cutting. We take 2 membrane rolls, and we always start the membrane roll from the point of rupture to increase the yield of diagnosis of chorioamnionitis. And we also take 2 sections of umbilical cord, one from the fetal end and one 5 centimeters from the insertion point, sampling any obvious cord lesion. In terms of the placental disc, at least 3 full thickness sections of normal looking placenta from the central 2/3 of the disc is recommended, including a site at the site of cord insertion, as I've depicted here. And the rationale for taking these 3 parenchymal blocks is to increase the pickup of chronic velitis. Now, in some centres, including my own, we take only 2 central sections, and we take a marginal section at the point of membrane insertion. And some centres also elect to take a decidual plate shave, particularly in the setting of preeclampsia or fetal growth restriction. Obviously, if there's any lesion, take a block from each lesion, up to 3 additional blocks. Now, often the placental disc is too thick to fit in a single cassette, so you can opt then to take a long, narrow slice, divide it in half, and squeeze that into one single cassette, or take regular width slice and then make composite blocks in 2 separate cassettes. And that's the preferred method at the green arrows at the top and the bottom. Now, there's a lot to remember when you're handling a placenta macroscopically. So this is a picture of what our pro forma is for handling these specimens at the cut-up, so that we have a prompt for each data point that needs to be added. And that's the end of my talk. Thank you for your attention, and I look forward to the Q&A.
Okay, thanks, Karen, for that excellent talk. Carlos, could you put on your video and maybe bring up your first slide, please? So again, it's my great pleasure to ask Carlos Parra-Haran to give the next talk on uterine corpus and lymph nodes. Again, Carlos is a very well-known gynae pathologist from the Brigham and Women's in Boston. He's very widely published and in demand to speak at lots of international meetings. So, Carlos, over to you.
Thank you, Glenn. And more importantly, thank you to Karen for that very comprehensive talk. There will be a little bit of overlap because we both talked about the uterus at some point. And most importantly, thank you to Morali for this gigantic effort to congregate so many people to talk about macroscopic pathology in 2024. And it's an honor to be one of those people. We're going to concentrate on specimens where there's uterine corpus pathology, with a brief mention of lymph node sampling in gynecologic pathology. The hysterectomy specimen is the most common scenario that we have to deal when we have endometrial or uterine mesenchymal pathology. And we're going to walk through most of those scenarios with brief mention of other uterine specimens that we see in our daily practice. A lot of the images and diagrams that I'm going to show you have been donated or have been kindly authorized for use by me from Dr. Marisa Nucci, so thank you to her. And the other, if there's one resource I want you to go find after this, is the very, very comprehensive and helpful practical paper on grossing and processing issues that the International Society of Gynecologic Pathologists published in 2019. This is already 5 years old, but it really at least set a consensus standard for many of the questions that we had in terms of how to approach these specimens. When you approach a hysterectomy specimen, every single time, find the indication for it even before you lay eyes on it. because that will determine most importantly, the sampling, right? You want to know why that hysterectomy specimen came to you. If it's cancer, if it's benign, if it has an obstetric indication, et cetera, et cetera. Orientation is something that we typically learn, and I know we have a diverse audience, so I'm not going to delve too much on that. But the vast majority of hysterectomy specimens can be oriented, which is important in the sense that sometimes determining the location of a particular pathology in terms of anterior uterine or lateral, anterior, posterior, lateral uterine wall may be important to know where to go back if you have to go back to the specimen. And sometimes for interpretation purposes, it's important to know, the laterality or the location of the lesion. So for those lesions, for those reasons, we try to orient the specimen as much as we can. You can look at the depth of peritoneal reflections. If you have a fallopian tube and an ovary, you always know that the fallopian tube is anterior to the ovary and the ovary is posterior with respect to the fallopian tube. In the vast majority of cases, the location of the serosa and the location of the end of both anterior and posterior peritoneal reflections is the most relying feature, the one that I look the most. We all know, hopefully we all know and appreciate in daily practice that the end of the anterior peritoneal flexure is more blunt. It has a blunt horizontal edge that is much upper into the lower uterine segment part of the uterus compared to the posterior reflection, which has a more angulated pointed edge and goes much more inferior, goes much more distal to cover part of the lower uterine segment wall. In terms of measurements, a few things I have to say, and throughout the talk, a lot of the things that are not explicitly stated in the ISGEP recommendation or in other management guidelines, I'm going to inject some of the personal approaches that I have to the macroscopy of these cases. The first one is that if you're going to measure, if you're going to obtain measurements from a hysterectomy specimen, this needs to be done at the fresh state when you first examine the specimen, not after fixation, because we all know that fixation affects the size and affects the weight of the specimens. Weight is required in the US for billing purposes. The billing codes change if the uterus is less or more than 250 grams. At least in some practices. So in the US, it's standard to record the weight of the uterus. But in other geographies, it may not be required. And in my opinion, it doesn't really add much to the pathologic interpretation exercise. In terms of dimensions, it is important to obtain at least one, these largest dimensions of the uterus and the ovaries. Fallopian tubes in terms of length and diameter is sufficient. And recording the length and the diameter of the fallopian tubes and the ovaries is, in my opinion, important, especially if they're detached or if you cannot really orient the specimen, because if you have to go back to those organs for later sampling, determining the size and the appearance of them may really help you identify them in a subsequent time. Margins. Well, margins are not really a thing when a tumor is confined to the uterine corpus, because the uterine corpus is completely or subtotally surrounded by serosa. So in most reporting guidelines and synoptic reports, we don't really need to report mandatorily the status of the margins. However, if the tumor is involving the cervix, or is approaching the lower uterine segment in some instances, reporting the status of the margin and sometimes the proximity of the tumor to the margin is required. The problem is we don't know if the tumor is involving the cervix at the time of the initial approach. And that's why if your practice in terms of time, staffing, resources allows, inking the distal part of the external uterine wall is preferred, because you really won't know if the cervix is involved or not unless you open the specimen and look, and in many cases looked at the histologic slides, right? So what does that inking entail? at least use one color. In our practice, we're fancy and we use two, one for the anterior and one for the posterior. But what you really want to cover is that area of the lower uterine segment and the cervix that are not covered by serosa, right? Now, from a surgical perspective, these anterior and posterior surfaces are not real margins. Those are just areas in which the surgeon releases the peritoneal flexure from the pelvic tissue. But these are planes that the surgeon dissects, right? Especially on the lateral sides. So we want to know if the tumor is at those surfaces, and that's why we ink them, if your resources allow it. Another margin that is important is that you could consider this a soft tissue margin, but you also have a mucosal margin, right? The point where the cervix ends and the mucosa of the upper vagina starts. That margin is relevant, especially if you have an intraepithelial lesion involving the cervix, or a tumor involving the cervix and getting really, really distal to it, so that reporting the status of that margin may also be important. So extending the ink up to that edge helps a lot. Of course, if you have a hysterectomy that includes parametrial tissues, it's recommended to ink the external surface of those parametrial tissues as well. Inspect the serosa as everything else and document areas of hemorrhage, adhesions, or obvious mass at the time of the serosa. That has important staging implications. After you inspect the uterus, we're going to open it, and we typically do it using scissors. In my practice, we always use scissors because you're only inserting one piece of metal, and then you're opening gently, at staggered times as you start exposing first the endocervical canal, then the lower uterine segment, and then the uterine corpus. I know some people have suggested, or some people perform this practice of inserting a forceps into the canal and then aligning the knife in between the forceps arms to guide the cut from the knife into the uterine cavity. We don't do this in my practice, and we don't do it because the insertion of the forceps into the cavity without you looking at it first can disrupt the tumor, can fragment the tumor or whatever is occupying that endometrial cavity. And tumor fragmentation can lead to a bunch of problems, can lead to artificial displacement into vascular spaces or tissue gaps. We avoid tissue fragmentation as much as possible. So I'm not really a big fan of this practice. I will never do it. I will do it with the scissors that allow for a much more gentle exposure of the cavity to your eyes. Inspection is basically visual. I always advise against washing excessively or touching excessively the uterine surface, because the epithelium of interest is going to be dislodged. If you find any lesion, it should be documented in terms of size. And by size, I say at least the largest dimension. You may not be willing to provide 3 dimensions, but at least the largest dimension should be always documented, because if that lesion is a sarcoma, the largest dimension is a staging criterion. If it's a carcinoma, there's mounting evidence saying that the tumor size is a prognostic variable, at least in terms of risk of lymph node metastatic spread. So for those reasons, documenting the size of the tumor is important. Some tumors, are unifocal, like this one, and measurement is easy. Some tumors are more sneaky, right, and don't produce a large fungating mass. They just produce this area of abnormality or fungiform thickening of the wall. When the tumor or the area of abnormality involves both anterior and posterior sides, there's really no consensus on how to measure this, other than I would advise measuring from here to here, basically measuring from one end on the endocervix to the other end. I think that's probably an overestimation of the tumor size. In my practice, when this is the scenario, we measure the largest tumor dimension in the anterior wall and the largest tumor dimension in the posterior wall. And we go with whatever is largest. There's no evidence beyond that or widespread consensus, but that's what we do. Sometimes the lesion is really, really hard to see. If I ask you to identify a potential lesion in this particular uterus, and I tell you it's over there, my residents usually say, well, yes, I believe you, but sometimes it's not that obvious. In those situations, just treat it as if you were not seeing anything. It's probably best to approach this as a uterus in which you really have to do extensive sampling if the lesion is not all, definitively there. Initial inspection obviously also involves determining whether the cervix is grossly involved or not. When you see a tumor that is really, really going distal into the canal, that's something that you should evaluate at the time of initial inspection. Sectioning typically involves cutting with a knife, with a long knife is my preference, at 5 millimeter intervals from fundus to lower uterine segment, at least. Perpendicular to the longest axis of the uterus, meaning in a transverse section, as you can see in this figure. Some practices or some pathologists advocate for the donut approach, and I don't have a real live picture of that approach because we don't use it in my practice. So I added a real donut. But imagine this is a uterus. Basically, if the uterus is still closed, you haven't opened it, that before opening or without opening it, you cut it in the same fashion in transverse full thickness sections. So you obtain the entirety of the wall and the endometrial cavity in the middle. The approach of that is that if you have a lesion, you may be able to visualize or to estimate the myometrial invasion or the invasion into the uterine wall much better. And that's actually quite helpful if a lesion is invading the lateral wall, for example, which we disrupt by cutting the standard way. The problem is that when you do this, it's difficult to estimate tumor size and it's difficult to reorient the specimen. So for many reasons, I guess, this has not been the recommended approach by most institutions and by most guidelines I'm acquainted with. I don't see a major reason against it, but it may be difficult to provide center metrics, so we don't use it. Always assess for myometrial invasion. Not all the times we write if we think something is myoinvasive, and then we get the slides and it's not. You may think this tumor is myoinvasive, and in reality, it's not. It's just entirely confined to the endometrium. Exophytic does not always equal invasion. You need to really look and palpate the uterine wall to see if you see areas of abnormality. These are more obvious examples in which the uterus is involved, the myometrial wall is involved by tumor, as you can see here. Once you've inspected the cut surfaces of that section specimen, I think you're done. At that point, you probably, or at least in our practice, that's the point where we put the specimen to fix informally. Some practices will proceed to sectioning and taking the sections right away, and that's completely fine. In my practice, we place the uterus in this open and section state in a corkboard, and we proceed to fixation informally. Okay, this is the only way I will put a uterus informally after it's been opened and thinly sectioned. Please never, and in 2024, never place a hysterectomy specimen that is closed, that has not been opened in formalin and expect that tissue to be fixed. Everything that is in the endometrial cavity is going to be autolyzed. I've seen it even a day after, uteri that were removed the day before, but were put in a container either without fixative or with fixative, but without being opened. Nothing is going to get into the endometrial cavity. Whatever you want to evaluate in the endometrial cavity is going to be autolyzed at that point. So I cannot emphasize this enough. And in practices where we have now availability of molecular testing, where we're testing ER, where we're testing PR, we're testing HER2, we're testing for molecular modalities. Fixation is so important. So this point cannot be overemphasized enough. Whether you take all your sections at this point or not, never put an unopened uterus in formalin or any other fixative without opening it first and exposing the uterine cavity to the fixative. We do that after opening by pinning it in a corkboard, but if you don't have a corkboard, at least put paper towels or gauze in between the sections that you've made, just so the formalin penetrates better once you put that specimen back into the bucket. Tissue sections for histology will depend on the condition or the indication for the surgery, and that's why knowing the indication from the get-go is so important. The standard sections that we take from a uterine specimen or a hysterectomy involve the cervix, and the standard sections are longitudinal sections that come from the anterior and the posterior uterine cervix. The sections from the lower uterine segment can be also perpendicular, as I'm depicting here. In some practices, that section is transversal, so perpendicular to what you're seeing here. I think that's okay, especially in cases in which you don't really see anything grossly going on in that area. And beyond that, we take between 1 and 2 sections from each side of the wall. So 2 sections, 2 full section thickness from the anterior and 2 full thickness sections of the posterior. This leads to usually between 4 and 8 tissue blocks, depending on how big the uterus and how many sections you took. At the very least, always put 1 full thickness section of the uterine corpus from the anterior and from the posterior side. And again, most cases will lead to between 4 and 8, average of 6 tissue blocks for a specimen that doesn't really have much going on. Of course, if you have a benign, grossly looking lesion, either clinically or pathologically, you want to sample it in addition to these standard sections, right? Sometimes within them. Any lesion that I see, if it's less than 2 centimeters, I usually just put the whole thing. It's easy to section, and submitting between 2 and 4 tissue blocks is probably, and I think that's what most people would recommend. If it's a lesion that is 2 centimeters or less in size, just put the whole thing through. If it's more than 2 centimeters, then approach it with the 1 section per centimeter rule. And that applies to polyps. It does not really apply to fibroids or tumors that are grossly compatible with a benign uterine tumor. In the vast majority of cases, a leiomyoma. And in these cases, we do a significantly more conservative approach because they're just so frequent. And in a single uterus, they can be so numerous that if you go by the rule of 1 section per centimeter, we're really going to lead to a lot of oversampling, which historically has never been forcefully indicated in our practices. I think this tradition of being very conservative in the sampling of grossly looking leiomyomas has panned out to be a safe approach. Beyond that, beyond knowing that it can be conservative, there's really no consensus on how many sections you need to take from lesions that look grossly like a leiomyoma. At Brigham and Women's, we set a limit of up to 4 blocks, regardless of the size, the number of the fibroids, and the weight of the specimen. And we put 1 to 2 sections maximum in each block, right? In Sunnybrook Health Sciences Center, which is the institution where I worked previously, the policy was to put 2 tissue blocks per each 5 centimeters of the uterus largest dimension. So if you've reached 5 centimeters, then you add 2 blocks to the mix. So if a uterus was 8 centimeters and you have at least 5 centimeters in that specimen, you put 2 blocks. If the uterus is 17 centimeters, then you increase it every time you get 5 additional centimeters of the uterus greatest dimension. Just to account, and this really sounds complicated, it's just trying to account for the variation in size and increase the sample a little bit if you have a much larger uterus occupied by fibroids. These are just 2 approaches that I've encountered in my practice. I think that there's nothing wrong with them. You can be quite conservative in your approach, and until we have maybe some evidence of better consensus recommendations, you can go with either of these or a similar protocol that you have in your practice. Prophylactic hysterectomies, typically in the setting of genetic conditions that predispose to endometrial cancer. The most common one in my practice is Lynch syndrome, but now we're seeing from time to time, we see patients with Li-Fraumeni or Cowden syndrome, patients with gene predisposition syndromes that predispose to ovarian cancers have also prophylactic hysterectomies because they also have a slightly increased risk of endometrial cancer. In these cases, because they're prophylactic, the vast majority of the time, they're grossly normal. The endometrial surface is flat, thin. In those cases, we submit the entire endometrium. With the same approach of having at least one full thickness section, and by full thickness, I mean you need to see the serosa from the anterior wall and one from the posterior wall. The remaining of the sections that will ensure that you've seen the entire endometrial cavity can be superficial sections, meaning if this is the full thickness, you can just take the superficial half or the superficial third. I will say, make sure that this is at least 5 millimeters in thickness, and then submit it in the block. This approach will let you put more than one or two pieces in each tissue block to save space and to save time, right? You're going to do the same. You're going to put the entire endometrial lining using the same approach in cases that have a preoperative diagnosis of endometrial cancer or a precursor, atypical hyperplasia/EIN. But on gross examination, the endometrium is normal, meaning you don't see anything that looks like a tumor. In those cases, you know that there's a preoperative diagnosis of cancer or EIN, submit the entire thing from the get-go. If you do have a tumor, again, the same approach applies. If it's less than 2 centimeters, the best advice is to submit it in toto, always attached to the wall, of course. If it's more than 2 centimeters, applies the 1 section per centimeter rule, always making sure that you have the full thickness sections, as I said before, that include appreciation of the serosa, always include the deepest point of invasion. And if there is any obvious relation with the cervix, the parametria, or the adnexa, put the tumor in relation to those structures as appropriate. And this is a pictorial description of what I just said. I will add, however, that if you have tumors in which you see macroscopically the edge of the lesion and you see grossly visible normal endometrium next to it, include that normal endometrium in your section, because then the exercise of determining myometrial invasion or deciding where the normal endomyometrial interface is significantly much easier. So try to include normal structures around the tumor as much as possible. And tumors in cases in which you have a suspected or confirmed diagnosis of sarcoma, the same approach applies in terms of size. And in terms of sampling, always include the 2 full thickness sections to include serosa. And of course, include the serosa that is closest to the tumor that you see macroscopically, and relation to any other structure, not just the serosa, but the cervix, the adjacent endometrium if it's a superficial sarcoma, the parametric structures, and the adnexa as appropriate. All of these concepts and all of these recommendations and approaches that I've shown you or that I've discussed apply to the grossing bench, but you can also use them if your practice receives hysterectomies for intraoperative consultation. It is not very popular. I will guess it happens mostly in North America, but there is some evidence to show that depending on certain variables, the risk of nodal metastasis changes. And the surgeon may want to know all these variables at the time of first section to decide whether a lymph node dissection on each side of the pelvis is warranted or not. Settings with sentinel lymph node samplings usually don't do this routinely. We only do it in my practice when the surgeon cannot locate the sentinel lymph node and therefore need to go back to the question of, do I take the lymph nodes on this side of the pelvis or not? And in situations or in practices in which sentinel lymph node protocols are not yet in place. Again, in those cases, the question is going to be, do I do lymph node dissection, or can I spare this patient from a lymph node dissection at this point of the hysterectomy? And they're going to do that based on a combination of factors. This is an algorithm published in 2017 that I actually like to refer to because it shows you all the characteristics that the surgeon uses to make that determination. Some of them are known from the biopsy, like tumor type and the tumor grade, right? If it's a high-grade carcinoma, they know that from the biopsy. we don't need frozen section or intraoperative consultation in those cases. The patient can be triaged to lymph node dissection, right? But if it's a low-grade lesion, then they want to know about the size. That's why I emphasize about tumor size measurement. And they want to know about myometrial invasion, LVI, or cervical involvement. And if you have any of that, if you have myometrial invasion, at least 50% of the uterine wall, if you have LVI or cervical involvement at the time of intraoperative consultation, that patient again is going to be triaged to lymph node dissection. If not, that patient is not going to get lymph node dissection, and you probably will spare her a lot of complications. I'm showing you this not because this is a class on intraoperative consultation, but to show you that these skills on approaching the uterus macroscopically can also help you in the frozen section room if you fall into one of these situations. Briefly about oral uterine specimens, in my opinion, they're a headache, but we do see fragmented or morcellated hysterectomies. The appreciation and the description of any abnormalities applies just like using the metrics that I mentioned. In these cases, I think it's especially important to document not only the weight, but the aggregate dimensions of, like, you can put all the fragments together and measure and aggregate, or at least mention the size of the largest and the smallest to give an idea of the range. And you should do your best to identify any structures that you're supposed to have there. And to know that, it's very, very important to correlate with the operative note, because sometimes the requisition doesn't tell you if you're supposed to have the cervix, or if you're supposed to have both ovaries or both fallopian tubes. So I always go to the operative note to make sure that I know what they took out. And then I go back to the specimen and make sure that what they took out, or what they say they took out, is there or not, okay? If it's not there after extensive search, then we probably need to say something to that effect in the report, right? So this type of correlation is very, very important. Myomectomy specimens that are only supposed to have one or several tissue fragments consistent with a leiomyoma should also be weighed and measured in terms of aggregate dimensions. If it's a single intact specimen, some people ink the external surface, because if that thing ends up being a sarcoma, the surgeon may ask you if you think that lesion was completely excised. That's controversial. If it's a single removed tumor with an intact external surface, sometimes we ink it in my institution because of the rare instance in which ends up being malignant, and the surgeon wants to know if the margins are negative. But in most instances, that will really not be necessary, because most myomectomies are removed in not one, but several fragments, and they end up being benign. Very briefly, about lymph nodes, regardless of where the gynecological cancer is coming from, we typically dissect them by inspection and palpation. The recommendation from our guide is to leave 1 millimeter of adipose tissue attached, especially if it's a grossly visible tumor in which extranodal extension may be a potential complication. Record the number and the size of the lymph nodes, and to this end, you can be conservative. You don't need to record the size of every individual lymph node. You can provide a range or the size of the largest and the smallest. A specimen size we consider is less informative, but it can give you an idea of how much fat versus how much lymph node tissue you received. You process that lymph node by cutting at 2 millimeter regular intervals, and the 2 millimeter to me has become very important, because we know that 2 millimeters is the difference between macrometastasis and a micrometastasis, and we know that this size of metastatic nodal disease matters more and more in gynecologic cancer. So cutting at 2 millimeter intervals perpendicular to the longest axis of the lymph node is very, very important. Grossly involved lymph nodes can be partially sampled. If it's obviously involved by tumor, you don't need to submit the lymph node entirely. 1 or 2 blocks suffice. But if it looks grossly normal, we put the whole thing in. We all know that, right? We typically don't put, if it's a small lymph node, you don't cut it if it's less than 2 millimeters. You just put the thing intact, right? We submit multiple lymph nodes per single block only if they're intact, and we can determine their number in the cassette key. If we section them, we try to keep 1 lymph node per block. or we try to avoid putting more than 2 multi-section lymph nodes in every single block. Other practices ink one of the, if you're going to put 2 section lymph nodes in one block, they ink one of them and then they put them there to know which section corresponds to which lymph node. That works well generally, but if you can avoid that to avoid confusion and misrepresentation of the lymph node counts, that will be better. I don't know how I'm doing in time, but this is the end. I hope this was useful and I look forward to the discussion.
Hey, thank you, Carlos. That was really excellent, and Karen's as well. Karen, if you're still there, I know it's very late at night or early in the morning for you. Would you be able to put your camera on, and we'll go through some of the questions? There are quite a few questions. We have about 15 minutes. We might go 5 minutes over. I think the next symposium is not till about.
You can take up to 15 minutes more if you need to.
Okay, right. Okay, so we'll try to go through. There are some questions for all of the speakers, so we'll maybe ask a couple of all of the speakers and then go back to see if there are any more. So I'm going to start with Karen. There's a question about the orientation of LET specimens. You know, I think I get the impression, I think in other places we kind of ink more and go more into orientation of LET specimens than in the UK. We virtually never do this. So it's really a comment about that, and how helpful is orientation regarding confidence of margin involvement, especially when these specimens are received in multiple pieces.
Yeah, well, first of all, the reason that we go to the trouble of inking and differentially inking is really because that's what our clinicians want. So it's a function really of providing the service to our clinicians, and that's the expectation from them, is that when we report a positive margin, we obviously say whether it's an ectocervical or an endocervical margin, but if it's an ectocervical margin, we provide a clock face orientation of where that point of involvement is. That won't mean that they'll go back and re-excise for an ectocervical margin, but I guess it provides some guidance to them when they're following the patient colposcopically. And obviously, if it's an endocervical canal margin that's involved, that's critical, because then they often will, for a high-grade dysplasia, go back and re-excise. So I think the rationale is really driven by the clinician's expectations. And also, I guess, when we're reporting it, just to give a more concise, as I was saying, a concise representation of the extent of disease. Is it involving both 6 and 12 o'clock halves, in addition to 3 and 9 o'clock ends? Now, when it comes to a fragmented specimen, the differential inking, you know, it doesn't matter. The margins there are essentially, I think, unreliable. And my practice is I'll say that there is dysplasia present at a margin, but I don't know how that margin relates to the patient in the setting of a fragmented specimen. So, I mean, we do our best. If it comes in 2 halves, we can be confident about the outer ectocervical, but the points where the tissue has been disrupted, we don't know what's a true margin there and what's not a real margin.
Okay,
So
yeah.
Hope that answers everything. Yeah.
Yeah, no, it does. I think you probably spoiled your clinicians compared to us in the UK. We don't go into all this effort.
Yeah.
So I'll just one more quick one for you at the minute, Karen. You did mention about the ISGIP recommendations for fallopian tube in cervical cancers. You mentioned CFIM, and somebody maybe just clarification what ISGIP are recommending us to do in cervical cancer specimens when the tubes are removed.
I think part of it is going through the motions of a dedicated macroscopic examination by making multiple slices into the tissue. And the whole point of it is to increase the yield of pickup of metastatic disease to the adnexal structures. There isn't a great evidence base in terms of how much you should sample. There is no evidence how much you should sample in the setting of normal looking ovaries and tubes in this context. So we're talking about a cervical malignancy when you've got a radical excision, which includes adnexal structures. and the ISGIP guidance is really to provide what the minimum recommendation is and leave it up to you. So the minimum is entire fimbrial ends and representative tube and ovary. And then at the other end of the spectrum, if you want to be completely meticulous and look at everything, you can put the whole lot on. We don't do that in practice. Actually, I guess first thing to say is we don't get ovaries and tubes very often. We don't get those sorts of radical excisions very often. And in the context of normal looking ovaries and tubes, we wouldn't put the whole ovary on. We would just sample representatively. But the aim of the CFIM approach, I think, is to allow for thorough macroscopic assessment for presence of metastases.
Yeah, so I guess they're not really recommending that you put the whole tubes through in all cases, you know, so it's just what we would normally do anyway. It's the fimbria and representative of the tube. So just a couple for Carlos then. I know we often take parametrial shaves and peritoneal, you know, from in simple hysterectomy specimens for endometrial cancer, but would you routinely do that in hysterectomy specimens for benign lesions, especially when they're wondering about endometriosis?
Oh my God, that's a great question, and I would love to know what you two do, because we don't do that here. If it's a benign hysterectomy, meaning what's done for a protracted uterine bleeding with no confirmation of cancer, leiomyomas, suspected adenomyosis, prolapse. We don't sample. Well, most of those cases are simple hysterectomies, right? In which case you do have an outer edge, but technically not parametrial tissue, right? So we include. I think when we sample in my institution, when we sample the lower uterine segment, we include that edge, we include that outer edge, but we don't take a separate shaving or a separate section from that area. I guess you break the possibility of detecting endometriosis, and that's probably, you know, now that you mention it, that's probably an approach I will take if the patient has such diagnosis, or if I encounter that endometriosis in the initial sections, you know, I may be compelled to go back. Although, if you already have it, if you already have a diagnosis of endometriosis, you know, the point of chasing after it in the parametrial tissue, it's debatable. So in those settings, in a benign hysterectomy, in my institution, we don't go after that. Do you?
Yeah. No, we don't take parametrial shaves we don't. So another question is, you know, let's say you got a hysterectomy specimen for menorrhagia or prolapse, and there's nothing to see grossly. I mean, obviously you take your 2 sections from the cervix and maybe 2 from the endometrium, myometrium. Do you routinely take a section from the lower uterine segment in those cases?
In my institution, we do, and that ends up. So we in my institution, a hysterectomy like the one you described will have 6 blocks. Sometimes 4 if the uterus is tiny, and you can put, we can usually fit either the 2 cervix sections in the single block, or the cervix and the section of the lower uterine segment in the same block. So we end up with 4 blocks. But more often than not, what I see is 6 blocks coming from 2 from the cervix, 2 from lower uterine segment, and 2 from the uterine corpus. Why do we sample the lower uterine segment? Well, I'm not entirely in those situations, right? I'm not entirely sure, other than the fact that in the lower uterine segment, sometimes you find unexpected things, just like if you would in the uterine corpus and in the cervix. I don't know what the ISGIP said in 2019 about this particular scenario. There's probably nothing about it. Because we're not talking about endometrial cancer patients. What do you do?
Yeah, I mean, I'm not actually sure what our protocol says. It used to be we would just have 4 sections from a hysterectomy like that, you know, 2 from the cervix and 2 from the endometrium stroke myometrium. But now I do seem to be seeing they're sampling the lower uterine segment. So I'm not sure if that's been written into the protocol or they've just kind of decided to do that. What about you, Karen, in Melbourne?
Yeah, our standard approach, we're a little bit unconventional. We take our sections, we continue in the same sagittal plane as the cervical sections, and we then we do a composite from the cervix up to the fundus, anterior and posterior. And usually it ends up being 3 sections on the anterior and the posterior, cervix, isthmus, corpus, and at the end up to the fundus.
Yeah.
Okay.
Yeah.
You know, that I actually love that approach, let me tell you.
And we do that across the board, benign and malignant.
Yeah, that means that, you know, so that deviates from the protocol that I described, which is just you first do transverse cut sections through the wall to examine it, right? When you do that, then you kind of do that nice longitudinal proximal to distal section you're describing, right? I think that means that you need to modify your sectioning protocol to align to those longitudinal sections. I don't have nothing against that because you're still sectioning the wall and you're appreciating intramural changes. That's another approach that allows you to include the lower uterine segment. I think that's a lot of this is determined by the practice. You know, when we started talking about patients with Lynch syndrome, and we had the Bethesda criteria that said, you know, these tumors, when you have a patient with Lynch syndrome and endometrial cancer, those usually arise in the lower uterine segment, right? So I think that historically, and patients and practices that see a lot of those patients like mine probably decided to start sampling the lower uterine segment in those populations, and it just permeated into all other instances. That's my explanation.
Yeah. So one more for you, Carlos, at the minute. I guess this is about measuring the depth of invasion and depth of myometrial invasion and endometrial cancers. It's really somebody's asking, you know, about the percentage depth of myometrial invasion. You know, how do you kind of do that? You know, is it in the area of the deepest invasion, or do you use the thickest area of the myometrium? And another, I would just add to that, in the UK, we don't measure, we just say whether it's inner or outer half. We don't actually give a percentage, you know. So just kind of your thoughts around those questions.
Yeah, well, first of all, I think the recommendation for staging purposes is what you just described. You just need to say whether it's less than 50% or whether it's 50% or more, right? Because that determines the stage and therefore the prognosis and the treatment for that patient. How do you get to that point? Well, of course, in some cases, it's going to be very easy. You know, you look at the slides, you look at the gross, it's not myoinvasive, or is obviously myoinvasive into the outer half. You know, in those cases, you don't need to really grab a ruler. I grabbed a ruler when, by eyeballing it, I'm really not sure if I'm in the 50% threshold or not. I think, and to answer the submitter's question, I think that requires a combination of gross, but most importantly, microscopic evaluation. There are practices like the one I used to work before in Sunnybrook, where we actually ask our PAs not to say anything about the myometrial invasion, because sometimes you will have a gross estimation. You would say that the pathology assistant or the pathologist will say, I think grossly this tumor invades more than 50%. And then you just look at the slides and it's all adenomyosis, right? And we had a couple instances in which the clinician called us and say, well, you said that it was more than 50, but it's not more than 50. Can you make your mind? So just make your, I guess what I'm trying to say is that if you're going to write a gross description and give an estimation of whether you think the tumor is confined to the endometrium or superficially invasive or deeply invasive, make sure that your final report harmonizes what you're saying, right? In case there's a discrepancy with the micro. And to that end, to me, determining myometrial invasion and the depth is mostly a microscopic exercise. At the time of grossing, obviously, whatever looks minimally invasive to you is what's going to guide the sections that you're taking, right? And that's why looking for it is so important. And if that's where the question was coming from, yes, you need to look at the area in which you need to locate the area in which you think the tumor has reached the deepest myometrial invasion, and that's where your section should be coming from. Whether that's the thickest area, if you count exophytic tumors, not necessarily. You may have areas of the tumor that are widely exophytic, but not as deep into the wall. I would rather choose the section, choose the area in which the tumor is closer or going obviously into the deepest parts of the uterine wall. And then you confirm that by microscopic examination, which has its own issues and disadvantages.
Yeah, so I agree with you. I mean, I think you bring up a very good point there that a lot of these protocols, they give kind of gross measurements and then microscopic, and you have to be very careful that they don't contradict each other. And we say this specifically in the cervical carcinoma, the ICCR protocol, that really one set of measurements, which is based on a combination of gross and microscopic, because of the gross says it's 7 millimeters deep, and the microscopic says it's 4 millimeters, and they don't know really what. So you have to be very careful, I think, not to contradict yourself. And it's similar to what you say, inner or outer half. You have to make sure they tie up, otherwise it's just very very confusing. So I'm gonna try to answer a couple of questions just that have been asked about my talk, and most of these are really around the CFIM protocol. And I'll maybe ask you both, Karen and Carlos, about the CFIM, what you do in your lab in a minute. But there are a few questions here, but they're all kind of related. Do we have to submit the fimbrial ends during grossing of non-malignant hysterectomy specimens? So I would say in all cases we should submit the fimbrial ends, because if something's going to happen within the fallopian tube, it's going to be in the fimbrial end. So you could argue you don't need to take to look at a transverse section, but so I would say you need to submit all the fimbrial ends and look at them microscopically. And then a question related to, the fallopian tube is the origin of high-grade serous carcinoma. Is it always the fimbria? I would actually say it's almost always the fimbria. It's very rare to get these high-grade serous carcinomas actually arising, away from the fimbria of the fallopian tube. Of course, nothing's impossible. There's a related question. There was a bit of maybe thoughts a while back, the endometrial serous carcinomas actually arise from the tube and then drop back into the endometrium. So I think that's not the case. Most of what we would call endometrial serous carcinoma is arising from the endometrium. Of course, you can get a tubal high-grade serous carcinoma, which kind of drops back, and then you just have to put everything together, including WT1, which may or may not help. And then the last one was, should the CFIM protocol be used in endometrial serous carcinoma and other high-grade carcinomas? Well, I don't know that there are any recommendations out there, but we did a study on fallopian tube involvement in endometrial serous carcinoma a few years ago, and if you use a CFIM protocol, you do actually upstage some cases. So you could argue that the CFIM protocol could be used in serous carcinoma of the endometrium. We personally, we don't actually do that. We just use it in extrauterine high-grade serous carcinoma when the tubes are grossly normal. But just Karen and Carlos, do you use the CFIM protocol in all cases, benign or malignant, or just malignant, or just high-grade serous carcinomas? And I guess this varies from place to place.
It probably does. I'm sorry. I thought you go ahead, Karen.
Sorry, Carlos. We have instituted the practice of doing the entire tubes for every high grade endometrial cancer. So anything other than grade 1 or 2 endometrioid gets the entire tube submitted. And I thought that was the recommendation that was in the ISGIP paper. And I think it's based around occult metastasis and upstaging tumors. So if you do that, you will inevitably upstage some proportion, a reasonable proportion of tumors. So we have adopted that practice.
I would say the same thing. For the same reasons. Yes, you increase the chance of an occult metastasis, which is, it depends on many variables, but one of them is tumor grade. So if you're dealing with a high-grade endometrial carcinoma, we've adopted that practice as well. The added value of it is if your high-grade endometrial carcinoma is serous, you may also find a serous precursor, and of course that opens a kind of worms, right? Like, is it truly endometrial, or could it be coming from the tube and whatever? But if you have a tubal carcinoma, then we've had situations in which that's at least a consideration, like could have been coming from the tube, and the uterus is a spread from it. In benign lesions or in benign hysterectomies or benign cases, we do the modified protocol, which is what you described. If you're going to sample the fallopian tube just for documentation purposes, sample the area that is more likely to have something that is clinically relevant to the patient, and that's the fimbria. So in our institution, we sample the fimbria, we submit the fimbria in toto, and then we put a representative section from the mid and the proximal portion.
Yeah, I'm just coming back. I know I was one of the authors, but I can't remember. So in the ISGIP endometrial cancer grossing recommendations, does it recommend to do a CFIM on, is it all high grade or just all endometrial cancers, or
I don't know.
You have to go on.
I'm pretty sure it's just the high grades.
Okay. Well, we can maybe look that up later.
And I know we debated it in our department as to whether or not we should do it. And I think we checked our local protocols here, and I'm pretty sure that our college had adopted it.
Okay.
I haven't checked it for a while, but we instituted into our practice. And I have to say, so far I haven't picked up any metastasis, but it's now embedded in our practice. So
yes.
Sure,
while Carlos is looking up that, I'll just ask you another question, Karen. How do you examine the maternal blood vessels in the placenta?
So I said in my talk that we do 2 membrane rolls, and we find the membrane rolls the best place to look for maternal vessels for decidual vasculopathy. And generally you'll pick it up in those membrane rolls. We also opt to take a peripheral section as well as the 2 central sections, and part of the rationale for that is to increase the yield of pickup of decidual arteriopathy. So we look at the maternal vessels there at the marginal disc. And also when we're selecting our central disc sections, it's important to take the sections where the decidua is intact so that you can visualize the vessels in the central basal plate. Some institutions do a horizontal shave of the decidual plate and put it face down to look at maternal vessels in the setting of preeclampsia or growth restriction, but that's not something that we've adopted. We find that we pick it up pretty readily just using the methods I've described.
Okay.
The ISGIP says the SIFing approach should be used in uterine serous carcinomas, clear cell carcinomas, and carcinosarcomas. While only the fimbrial end should be submitted in toto in other scenarios. Okay, and then later on, the authors acknowledge that while there is movement towards doing CFIM in all endometrial cancers, that's not universal. So at the very least, do consider it in those that are high grade.
So you probably should do it in high grade. So just another question, Carlos. It's really about the kind of issue of measuring endometrial cancers, which can be very, very difficult. And this is, it's not really important for tumor staging. it's not really, I would argue it's not really important for management. I know that kind of there's a Mayo Clinic algorithm which uses a 2 cm cutoff, and okay, it's something we do, but do you think it, is it, and it's, I think in the ICCR data set, it's a non-core element, but just some thoughts about that.
Yeah, my first thought is that this is one of those variables that kind of falls in the middle of the hierarchy of what's important and what is not. As you said, this is one of those elements that is important for certain geographies or for certain practices, or maybe for some individual clinicians, right? And that's where many of our practices need to be adapted to the local microenvironment. I work with clinicians. Well, to that and honestly, if it's something that your clinician is going to care about, it's a metric that can be easily obtained at the time of routine examination. I think going through the 3 dimensions of a particular tumor is probably a little bit cumbersome, but at least estimating tumor size. And to that end, you just want to know if the tumor is more than 2 centimeters or not, right? So, to that, and I agree that there are instances in which deciding what's the tumor biggest dimension can be difficult. For example, tumors that involve both anterior and posterior walls, right? But in most instances, at least in my experience, at least you can tell, this tumor is larger than 2 centimeters. So I think documenting that is easy, and it can be useful to a clinician now. More importantly, it can provide eventual data that could tell us if it's truly a prognostic variable or not.
Yeah, so that's fair enough. Just one question for myself, and I didn't mention it during my talk. With a thin walled cyst with papillary areas, probably is useful to give an estimate of the percentage of the ovarian cyst that has these papillary areas. If it turns out to be, if those areas look borderline, we're always told if it's less than 10%, we don't call it borderline, although I'm not sure how much that is practiced, to be honest. If it looked like a very good going borderline, I would probably call it, even if it was a bit less than that. But there's one other thing I want to talk to you about, Carlos. About the kind of, I presume you receive all your hysterectomies for endometrial cancer unfixed. So in the UK, we do all biomarkers on the biopsy, which is better fixed. In Belfast, we do the molecular and all the biopsies, and it's very difficult. Very often the operations are, we serve different hospitals, so the hysterectomy specimen won't come till the next day, and obviously it's kind of infixative, and you don't have problems like that? Are all your specimens coming from your local institution where they can come down fresh? You don't get hysterectomy specimens from elsewhere?
From elsewhere, no. We at this point in my institution, the specimens that are grossed in my lab usually are received locally, meaning they make it straight from the OR. But I know there are practices in which you have centralized processing, and the specimens can spend between 15 minutes and 2 hours in a car or in transportation, right? I mean, that's a whole different topic, because the added logistic problem of transportation, is difficult to go around. You can put an fixative, but I think my recommendation would still be to open the uterus as soon as you can, as soon as it is safe, and as soon as you have the tools and the human talent and the infrastructure to do so. That uterine cavity needs to be exposed to formalin, because otherwise, we've all seen uteri where that was not the case, and assessing even the most basic histologic features of the tumor is extremely difficult because of autolysis. So I've always been an advocate of fixation as soon as possible. And yes, in terms of biomarkers, that they can be safely done in a biopsy, but sometimes you won't be able to, or sometimes you will have to repeat it, right? So sometimes the biopsy is so scant that you cannot really do everything you want to do in that particular specimen. So the fixation needs to be a priority that may be difficult to guarantee in practices like what you described, but that should be addressed to the best of your abilities.
Yeah, no, I agree. And I mean, unfortunately, things like mismatch repair immuno and P53 are ones which tend to be particularly prone to fixation issues. So it is a bit of an issue. I think we're coming towards the end. I'll just maybe ask Karen one more question. It's really about dealing with let specimens. If the cytology is suggesting a glandular abnormality, do you deal with the lets in a different way, or do you still do the parallel approach, which we kind of do in our institution and most places in the UK? I think, do you do any differently if it's a glandular lesion?
No, we don't do any differently. So our clinicians will do a type 3 LEAP or a cold knife cone for excision of adenocarcinoma in situ or suspected AIS, and we handle them all the same way. We still parallel sagittally slice them. We look harder if we don't find something in the first round of levels. I mean, for high-grade dysplasia as well, I feel like we probably do a little bit more on our leaps, but than a lot of places do, but we do level them to extinction if we don't find a lesion. So we just have a standardized approach to cutting and tailor the number of levels that we look at until we are satisfied that we've exhausted the tissue to find the lesion. Yep.
Okay, that's fair enough. Well, I think Murley did say we could go 15 minutes over. We've gone 17 minutes.
Well, I think you owe me something for 3 full minutes.
Yeah.
I'll send you the invoice.
That's okay. The check will be in the post, and I think Karen, it must be what 17 minminutes past 1 in the morning.
Yeah, yeah.
So
Thanks, Karen. Much appreciated.
Yeah. So I'd just like to thank Carlos and Karen for their excellent talks, and also Murley, Murley's the bane of my life. He puts all these things together and gets me involved, but it's good fun once it happens. Murley, do you just want to say a few words to finish off?
Just to express my thanks. I always like to say, I have, Glenn, my modus operandi. I get all you guys to do all the work and I take the credit. Right. So that's how it works. But thanks for doing all the work. Excellent sessions. Thanks.
Okay. Thank you, Murley. Thank you, everybody.
Not just the webinar, but also the papers. And I must reiterate, to all who are attending, I think these webinars are great, but you have to go back and read the paper. I think it's. I don't think, I'm not, as I always say, I'm not a fan of teaching by PowerPoint. You need to read the paper and understand what's in there. And since it's open access, you have no excuse for not reading it.
Okay. Agreed.
Great. Thanks all.
Thanks, everybody.